Hi everybody and welcome to our module on burns. A burn injury is a thermal injury to skin. Burns are diagnosed clinically by examining the patient and examining the skin. And we characterize burn injuries based on two things. One is the extent of injury, meaning how much of the total body surface area of skin is involved. And the other is the depth of the injury, meaning how far down into the epidermis, dermis, and lower tissues does the burn injury involve. For characterizing the extent of a burn injury, there are two ways this can be done. One is to use what's known as a Lund-Browder chart. That's what's shown on the left side of the screen here. It gives percentages based on whether the feet, the legs, the hands, the arms, and the head are involved. You'll notice that the chart has an A for the head and B and C for the legs. That's because the Lund-Browder chart has different values depending on whether or not the person who is injured is a baby, child, or adult. So the Lund-Browder chart is a very precise way to estimate the extent of injury. The way that's more commonly done, which is less precise, is the rule of nines. It assigns a surface area of 9% to most body parts, so the legs are 9%, the bottom of the back and the abdomen are 9%, and the chest and the top of the back are 9%, and then the head and the arms are each 4.5%. So most people use the rule of nines. The Lund-Browder chart is the more precise method. For classifying burns in terms of death, the old system was to assign burns a degree. This is what was in place when I was in training. So by this system, burns could be first degree, second degree, third degree, or fourth degree burns. That system has been replaced, although you will still see many people use it, and I'll talk about it in this video. The new system gives a name for the depth of the burn. So the most mild form of a burn is a superficial burn. This involves only the epidermis. In terms of increasing severity, the next level of burn is a superficial partial thickness, followed by a deep partial thickness, and then a full thickness. And then even in the new system, we still call burns fourth degree if they involve the epidermis, dermis, and the underlying tissue. And in the next few slides, we'll go over what each of the different depths of burns looks like clinically and how you can make the diagnosis. A superficial burn is what used to be called a first degree burn. This is the mildest form of thermal injury to skin. It involves only the epidermis. Superficial burns are painful. Burns that are painful are actually a good thing. Deeper burns are non-painful because nerve endings have been damaged, so when there's pain, this actually suggests a milder injury. Superficial burns are also red and they blanch, meaning they turn white with pressure, and they kind of look like a sunburn. This is a picture of a superficial burn on the screen here. Importantly, there are no blisters. If there's blistering, it's a deeper burn than a superficial burn, and these usually heal within a few days, and they usually don't require much treatment at all. Superficial partial thickness burns are what used to be called second degree burns in the old system. They involve the epidermis and some of the dermis. And what makes these types of burns distinct from the superficial burns is that they often form blisters. This is a picture of one on the screen here. You can see the red burn down here, which is a superficial burn, but then you've got a blister here, and that makes this a superficial partial thickness burn. These burns are painful, they're red, they blanch with pressure just like the superficial burns. It's really the blisters that make them distinct. And these take a longer time to heal than superficial burns, usually about 7 to 21 days. Deep partial thickness burns were also called second degree burns in the old system. These burns also involve the epidermis and they involve almost all of the dermis. They can be erythematous, but they also can be yellow or white, and they almost always blister. This is a picture of a deep partial thickness burn on the screen here. You can see this white area here. The skin in these burns is often easily unroofed. You can see that the skin's been pulled up here. That's because the tissue has been damaged and it moves. And these burns are painful to pressure only. If you press on them hard, the patient will feel pain, but otherwise the patient has lost sensation, and that's because nerve endings have begun to be damaged. In addition, these types of burns do not blanch like superficial and superficial partial thickness. These usually take more than 3 weeks to heal, and when they do heal, they often leave scarring behind. And then finally, full thickness burns are what used to be called third or fourth degree burns in the old system. These burns involve the entire epidermis and the dermis, and they can even involve the underlying tissue like the fat, fascia, or muscle, and when they do involve the underlying tissue, they're called fourth degree burns. This is a picture of a third degree burn at the top of the screen and a fourth degree burn here at the bottom of the screen. These burns are painless because all the nerve endings have been destroyed. And these burns almost always require surgery because without surgery, they will scar and there will be wound contracture. Full thickness burns often form an eschar, which is this dark necrotic tissue you can see in this picture at the bottom of the screen. And this type of tissue generates a lot of edema beneath it, and also the wound can contract. And this is a setup for compartment syndrome. So for this reason, full thickness burns usually need an eschar-otomy, which is an incision made in the eschar to relieve pressure beneath the lesion. If you don't do this, burns in the extremities will lead to compartment syndrome there, burns in the abdomen can lead to abdominal compartment syndrome, and burns in the chest can lead to a compartment syndrome that impairs ventilation. Let's talk about airway management in patients who have had burns. You need to watch for inhalation injury from smoke in patients who have burns. This can lead to airway edema, and that can lead to respiratory compromise. So in any burn patient, you want to look for coughing or wheezing. You want to look for inflamed or singed nasal hair. That's a classic sign of airway damage from heat and smoke. And then you also want to watch for evidence of respiratory distress and hypoxia or hypercapnia. In addition, always remember that patients who inhale smoke can develop carbon monoxide poisoning or cyanide poisoning. Many plastics produce cyanide when they are burned. So especially in a board question, you always want to consider these two things. And the reason you always want to assess the airway in patients with burns is because many burn patients require intubation and mechanical ventilation until their airway has had time to recover from injury. So now let's talk about burn treatment, and we'll start by talking about minor burns. So minor burns are superficial burns, like I mentioned earlier, or they can be partial thickness burns that only involve a very small percentage of total body surface area, or even sometimes full thickness burns that involve a really tiny percentage of total body surface area. In general, these burns are minor in terms of either depth or percentage of surface area that's involved. And the treatment for these types of burns is to cool the skin, clean it with soap and water, apply a dressing with topical antibiotics, and use things like acetaminophen or NSAIDs for pain control. And then most burn patients are given a tetanus immunization if their tetanus status is not up to date, and that's because there is a small chance of acquiring tetanus after a burn. Treating patients with more severe burns is different, and one of the reasons it's different is because these patients enter a hypermetabolic state. Patients with extensive burn injuries have massive protein and lipid catabolism. They can even have protein loss from muscle wasting because they are consuming the protein in their body. These patients also develop insulin resistance, so they can develop hyperglycemia, and their body temperature can become increased. In other words, they can get a fever, all because of the hypermetabolic state associated with their burns. These patients also usually have a persistent sinus tachycardia. And all these things can be seen in any form of massive trauma, but they are also seen in patients who have extensive burn injury. And because patients with burns have all of these things going on, you can apply the sepsis criteria to diagnose infection. In other videos, I talk about diagnosing sepsis. Some of the criteria include tachycardia and fever, but all these things are present in severely burned patients. So just because they have fever and tachycardia, you can't use that as evidence that they have infection. Patients with extensive burns also need fluid resuscitation because there are massive fluid losses associated with large burn areas. When you lose your skin, water evaporates from your body and massive amounts of fluid can be lost quickly. And the usual definition of a large burn area that's going to lead to fluid loss is greater than 10% of the total body surface area in a child or 15% in an adult. To determine how much fluid a burn patient should receive, one way you can do this is through the Parkland formula. This estimates the fluid requirement that the patient will need. According to this formula, the milliliters of lactated ringers that the patient is going to need is equal to their weight in kilogram times the percent body surface area that is burned times 4 milliliters. Whatever that number turns out to be, you give half of it over the first 8 hours and the second half over the next 16 hours. You also can give fluid boluses and titrate them to achieve a urine output goal of more than 0.5 milliliters per kilogram per hour. This is a very good urine output and suggests that you have adequately resuscitated the patient with fluids. Burn patients need topical antimicrobial agents to prevent infection. I've listed some of the common ones used here. Basically, all of these are bactericidal agents that you can apply as a cream to the skin to try and prevent the development of infection. And then with extensive burns, patients usually require surgery. This is usually done 1 to 3 days after the burn injury occurs. The goal is to excise the necrotic tissue and cover the burned wound. There are a couple of techniques that can be used to cover burned wounds. You can excise the necrotic tissue and then directly close the wound with sutures. You can use a skin graft where you transplant healthy tissue to the burn site. And then there's also what's known as flap surgery. This is where you stretch a flap of skin over the wound area and secure it and allow it to heal. Infection control is a major element of treating burn patients in the hospital. When the skin has been damaged, there's a high risk of bacterial infection from bacteria gaining entry into the body and the bloodstream. The first few days after injury, most infections are due to skin flora from gram-positive bacteria like staph and strep. And to prevent this, we apply topical antibiotics like we talked about earlier. 5 or more days after the burn injury is when gram-negative bacteria begin to colonize wounds. These are acquired from the respiratory and GI tracts or from the hospital environment, and the bacteria that often cause infection at this point in time include Pseudomonas. Pseudomonas is a classic cause of infection in burn patients, also E. coli, and also sometimes fungi like Candida. Administering prophylactic systemic antibiotics to burn patients is not generally done, and that's because this hasn't been shown to be effective. Systemic antibiotics are usually only given if there are signs of infection. This could include things like a spiking fever, changes in wound appearance like pus near the burn site or spreading erythema out from the burn site, or worsening pain in the skin around a burn injury. Wound cultures are often done to identify the specific bacteria so that you can treat it with targeted antibiotics, and the treatment is to debride the areas that are infected and use systemic antibiotics that are targeted to the specific bacteria. Some other issues around treating burn patients: these patients are often in exquisite pain, so pain control with opioids is often necessary. Burn patients can easily develop gastric or duodenal ulcers. These are called curling ulcers. They're a special form of ulcer that occurs in burn patients. The mechanism is the fluid loss from the burns leads to hypotension in the stomach and mucosal damage, and these patients develop ulcers in the stomach or sometimes the duodenum. And because of the propensity to develop curling ulcers, burn patients are usually administered ulcer prophylaxis with a proton pump inhibitor. And then lastly, these patients need nutritional support. Remember, they're in a hypermetabolic state, so they need lots of calories so that they can heal. And some patients are unable to eat enough calories, so many patients require tube feeds or a TPN while they're working through this hypermetabolic state. And that concludes our module on burns.